Welcome everyone, and thank you for joining us in the 2019 webinar series of Jonas Nursing and Veterans Healthcare, the signature program of Jonas Philanthropies. I am Dr. Althea Hicks, the Grants and Programs Manager here at Jonas Nursing and Veterans Healthcare, and please note that this webinar is being recorded. Founded by Donald and Barbara Jonas, our program works in partnership with schools of nursing around the country to identify and invest in high potential doctoral nursing scholars. It's not working. We are the first and only privately funded program in the nation with a presence in all 50 states. And we're focused on a commitment to the nursing profession and veterans healthcare with over 1,200 scholars funded to date. Be sure to follow us on our Facebook and LinkedIn pages at Jonas Philanthropies, on Twitter at Jonas Impact, or on our website at www.jonasphilanthropies.org. You can also check out our media library of recordings on our website at www.jonasphilanthropies.org. Please note again that you can use the chat feature if you have questions, and our staff will monitor and help moderate the questions throughout the session. And please make sure that your volume is muted. Today's webinar will be included in our Barbara Jonas Memorial Lecture Series, and it is entitled iServe2, the effects of parental military service on military-connected children. Our presenter today is Dr. Alicia Gill Rossiter, who is a Lieutenant Colonel of the United States Air Force Reserve, Nurse Corps retired, and is an assistant professor at the University of South Florida College of Nursing. Also serves as the director of the Veteran to Bachelor of Science in Nursing program and the military liaison. She retired in June 2015 after 25 years combined active duty service in the Army Nurse Corps and reserve duty in the Air Force Nurse Corps. Dr. Rossiter was instrumental in development of a first of its kind introduction to military and veteran health course. She received her doctorate in nursing practice at University of South Florida, where she was a Woodruff Jonas Veterans Healthcare Scholar and an American Academy of Nursing Jonas Policy Scholar. Her DNP grant-funded Jonas Center project focused on women veterans with post-traumatic stress disorder secondary to military sexual trauma. Additional areas of research and scholarship for her include the effects of parental military service on military-connected children and transitioning needs of medics and corpsmen into the professional role of nursing. We again thank you for joining us today. We thank Dr. Rossiter for being so helpful in this presentation, and now we'll turn it over to her to begin.
Good afternoon. I want to thank the Jonas Philanthropies for the invitation to present on iServe2, the effects of parental military service on military-connected children. Thank you for the introduction, Althea. Military-connected children became a topic of interest for me through my personal and professional interactions with military children in the community, within my practice, with my own children, and having been a military child myself. Having worked with over hundreds of military-connected children in Tampa, Florida, both in my role as a reservist at MacDill Air Force Base, which also happens to be the home of CENTCOM and SOCOM, as well as a school-based nurse practitioner, I saw firsthand the impact of military service on military-connected children, especially during the influx of children coming to the Tampa Bay area after 9/11. This is particularly true now that we have been a nation at war for over 18 years. We know that military service members and veterans have a unique occupation and cultural context that can have a real and lasting impact on their health. And while there's a fairly robust range of research on service members and veterans and the impact of military service on their physical and psychological health, little is known about the impact of military service on the children of veterans. So my goal today is to talk to you about the impact, as well as strategies to mitigate the impact of parental military service on military-connected children. Oops. I don't think I have control. Sorry. I can't move my slides. Okay, let me try now. No.
Just advance it. Just can you click it?
Althea, I'm just going to have you move the slides if you don't mind. So before we begin, I have to state that I have no disclosures, funding sources, or conflicts of interest, and that the views expressed in this presentation are those of the author and do not reflect the views, official policy, or position of the University of South Florida, Department of Defense, or the United States government. Next slide. So our learning objectives for today are: number one, describe military culture, military family, the deployment cycle, and the impact on military children. Two, to appraise factors affecting risk, resilience, and health-seeking behaviors in military children. Three, to construct approaches for healthcare providers to use the iServe2 strategy to create a supportive environment for military families. And four, to discuss the impact of policy and research on improving healthcare outcomes for military children. Next slide. Since the onset of the wars in Iraq and Afghanistan in 2001, military personnel have experienced more than 3.3 million deployments. Currently, there are approximately 1.3 million service members serving on active duty and another 818,000 serving in the Reserve and National Guard. Roughly 58% of those who serve have family responsibilities, at least one child, and roughly 40% have 2 or more children. Over 1.7 million children have the distinction of being called a military-connected child, and they're young. About 78% of active duty children are under the age of 11, and 80% of Reserve and National Guard children are under the age of 15. In addition, there are 1.8 million children of veterans who have separated or retired and have assimilated back into civilian life. When we look at the numbers, it's important to note that military service is a family business. According to the Department of Defense, 80% of recent troops come from a family where at least one parent, grandparent, aunt or uncle, sibling, or cousin have worn the uniform. More than 25% have a parent who has served. This is why it is so critical to have an understanding of how parental military service impacts military-connected children, and to adequately support these children so as not to disenfranchise them from wanting to serve in the military, as well as to support their physical and psychological health so that they are healthy enough to serve should they choose to serve when they become an adult. Next slide. So I think this quote really describes what life as a military-connected children is like and why military service can have such a profound impact on them, which is primarily positive, but unfortunately there can be some negative aspects and risk factors. In the military, we often hear that if the military wanted you to have a family, they would have issued you one in your duffel bag. All joking aside, those of us who serve do have family responsibilities. As I mentioned earlier, more than 50% of those who serve do have children, and military service does have an impact on the family members who support that service member. As Althea mentioned, I am retired military, and I also come from a military family. My great aunt and grandfather served in World War II and received a Purple Heart, and I had several uncles and cousins who served in all the conflicts starting back with Korea. My father also served as a Navy pilot, both on active duty and in the reserves for 30 years. So I was a military child, or a military brat, as we are often called. And my brother, who was married with 3 kids, joined the Army post 9/11 at 34 years of age and served for 9 years in the reserves, which included a 15-month deployment in Iraq and Afghanistan. When I joined the military on active duty, I was single. However, during my time in the reserves, I got married and had 3 children. And my children are now 22, 19, and 17, and they have only known me as a dual career parent, both civilian and military career. So the United States has been a nation at war for over 18 years. Blue Star families, which are those who have had a service member serve in combat, have experienced multiple deployments over the past 18 years. Some of these service members have had more than 10 deployments in their time frame or their time serving. Many service members are returning to families with both the visible and invisible wounds of war, and parents of service members, spouses, and children are taking on caregiving responsibilities and an increased burden of care. Sadly, there are 15,000 children classified as Gold Star children. A Gold Star child is a child of a service member who died while serving in combat. So this quote on the slide was from the April edition of Military Officer magazine, and April is the month of the military child. As with any month that is set aside to honor and raise awareness for an issue or cause, really we should be recognizing and appreciating all military children for their selfless service every day. So I want to extend my appreciation to all of you listening to this webinar who have served not only on active duty or in the Reserve or National Guard, but also to any spouses or military connected children, because we know you serve too. So next slide. So when you think about our active duty forces, these are those whose military service is their full-time job. They live, work, and play in a unique and distinct culture. The military is their full-time job, 24 hours a day, 7 days a week, 365 days a year. They can be called to deploy anytime, anywhere, and sometimes in 24 hours or less. So they live in that constant state of readiness and preparedness. In addition to deployments, they can also be faced with short-term or long-term separations known as TADs or TDYs, meaning temporary duty. And this can last for a few days to several months at a time. And these are usually to attend a school or training. It could be to fill in at another base or to serve in a foreign country on a humanitarian aid mission. For those who serve, there's a sense of patriotism and positive image. In the military, we also speak a different language, even between the various services. For example, the place where we eat our meals may have different names depending on your branch of the military. So it could be called a dining facility or a DFAC or a chow hall or a galley, depending on what branch of the military you're in. We also use a lot of acronyms, and we also use military time. So when that military child tells that civilian child that they have to be home at 1700, oftentimes they get funny looks from their peers. Next slide. The military culture and lifestyle provides for many amazing opportunities and experiences, such as travel, working and living in diverse countries and cultures. And military connected children live with a sense of patriotism and respect for the role their parent plays in providing for the safety and security of our country. However, they may endure multiple deployments and separations from their parents or parent. Because they are frequently moving, military-connected children are less prone to risky behaviors or substance use. Typically, they live on or near a base where they have lots of eyes watching them, other military families keeping an eye out for them. There's lots of rules that they have to adhere to, being an active duty child. They also move frequently, so this provides them with an opportunity to reinvent themselves with every move. Military families tend to be financially stable, meaning they are employed and they get a steady paycheck every 2 weeks, unless there's a government shutdown. But for the most part, they have a steady income every month. In addition, they have access to a multitude of resources and supports on that military installation, such as housing, commissary and PX privileges, recreation facilities and activities, schools, childcare, healthcare, religious facilities. These are all located on that installation. All active duty service members and their families have healthcare access as well as insurance through TRICARE, that's the military insurance. They have support not only from their traditional family, but they also have support from their military family, which is that family that you reside with during your tour of duty on a military installation. Most active duty families are geographically separated from their extended family, and this is why that military family is so important. They're the ones who step in when you're sick and you need to have someone take your child to school, or you've had a baby and they bring, dinners to you and support you during your spouse's deployment. For those who have a wounded warrior or a recovering service member, they may be geographically separated for care, and that family may have to travel or move temporarily to be with that wounded warrior. The mobile lifestyle can lead to disruptions in social support networks and established resources. This can affect continuity of care. Not only might you be moving, but your providers are constantly moving or deploying as well. So you may never have an encounter with or develop a relationship with your primary care provider. Or just when you start to get to know that primary care provider and they get to know your children, they may move or deploy. And for our military connected children, this also means disruptions in their education. On average, military children can attend 6 to 9 different schools from kindergarten through 12th grade. Next slide. So conversely, members of the National Guard and Reserves are the citizen soldiers who live and work in civilian communities across the country. They may live near a military facility or they could be remote. Some Reserve and National Guard members travel long distances, which can lead to a lack of support or camaraderie from their unit for that service member and their family. And this lack of support can be troublesome, especially pre, during, or post deployments when service members and their families are at the most vulnerable stages. When I left active duty and joined the reserves, we were considered backfill. So basically our role was to take over for the active duty forces when they deployed and filled their jobs stateside. But after 9/11, all that changed and the reserve forces went to what was called a mirror force, where we mirrored what the active duty did to include deploying. So currently our reserve forces are deploying at higher and higher rates, sometimes even more so than the active duty forces, especially if they have a unique identifier for a job code. In addition, the National Guard, whose primary role is to support individual states in times of natural disasters and civil unrest, they are also now deploying to combat zones and have been deployed multiple times. Next slide. So when the Guard or Reserve parent is called up to active duty, the children suddenly become military. Children of National Guard and Reserve forces tend to remain geographically stable, but typically reside in communities that lack knowledge of the requirements and demands of military service. Children of National Guard and Reserve forces attend schools where they may be the only child in the classroom with a parent or parents serving in the military, and they may also lack an understanding of the military and what resources or support networks are available to this military family in the community. Additionally, faculty and administrators may not have knowledge and understanding of military life and the related stressors on military children. Serving in the Reserve or National Guard can also end up being an additional stressor for that service member and their family members, because they must maintain not only their civilian career, but also their military career and all that entails. So things like certifications, education, job training, all those things that they have to do to support that additional career occupation. And oftentimes their civilian job may be different than their military job. So you could be an accountant in your civilian job and a military police officer in your military job. So trying to juggle 2 different careers and all that entails can be significantly stressful for our Reserve and National Guard members. And there are studies that support the premise that communities, schools, and civilian healthcare providers have little to no understanding of the military culture or awareness of resources and referrals within the community, and this can put these children at much higher risk. Children of National Guard and Reserve Force families are not eligible to access the many services provided to the active duty service members on military bases, such as healthcare, childcare, and recreational programs. Also, there could potentially be a shift in financial status. Typically, but not always, they may make less than what they were making in their civilian job, which is coupled with the fact that that parent who gets called to active duty, who might have typically been the parent that was home every night for dinner or attending all the school events, they may suddenly be gone. And once again, this is a significant stressor for these military connected children. Next slide. So fortunately, the term used to describe most military children is resilient. Military children definitely bloom where they're planted, and this is why the dandelion is the official flower of the military child. And they are resilient because they've developed a process of adapting well in the face of adversity, trauma, tragedy, threats, and stress, and they bounce back very well for the most part. If you ever want to confuse someone, ask a military child where they're from, and most of them will tell you wherever my family is. Next slide. Yet with all the positive, risks still exist. We know that after 18 years of war, military-connected children have been exposed to a large number of stressors and uncertainties that put them at a higher risk for physical, psychological, and behavioral health issues. The literature is just beginning to show that military-connected children are at a higher risk for abuse and neglect, substance use, and suicide when compared with non-military connected children, and this is even more of a risk during a parental deployment. They experience stress and depression related to parental deployments or post-deployment physical and psychological injuries such as polytrauma or traumatic brain injury, PTSD, or military sexual trauma. A significant number of military children have experienced the death of a parent. They may have changes in behavior and or academic issues secondary to emotional distress related to frequent moves or parental deployment. They might experience anxiety that can lead to changes in appetite, disrupted sleep patterns, and impaired immune response, which can impact overall physical and psychological health. And it's critical that healthcare providers, we shift our focus to include policies focused on addressing the impact of parental military service, so as to minimize the overall health impact on military-connected children and to support and strengthen the military family. And really, this is vitally important to national security, as we know that in order to have a healthy, resilient service member, it is imperative that we have a healthy, resilient military family. And readiness or the ability for that service member to do their job can be impacted by that family unit. Dissatisfaction of the at-home spouse and or the military-connected child is the #1 reason why service members separate. Next slide. So knowledge of the deployment cycle is critically important to supporting the military family. Being proactive versus reactive will mitigate the impact of that deployment on the children. So there are 3 phases of the deployment cycle. The first phase is the pre-deployment phase, and this usually happens roughly 3 months prior to departure. Typically during this stage, denial, anger, sadness, frustration are all feelings that the military child might experience. There's a lot of fear of the unknown. There's that anticipatory grieving for the parent who will be gone. Families will typically say that we're in the bucket during that phase, and that means that they are in preparation for deploying. This includes things like trainings, immunizations, getting their legal affairs in order, a whole host of activities that occur prior to that deployment. The second phase of the deployment cycle is the actual deployment. And this can last anywhere from 4 months to 12 months, a little less, a little more, depending on what branch of the service you're in. During this period, family members may experience loneliness, fear, sleeplessness, anxiety, adjusting to be alone, detachment, and our military-connected children are a high risk for neglect and abuse during this phase. When you think about all that's going on during this time frame, plus the exposure to 24-hour-a-day, 7-day access to news media, it doesn't help. We also know that the mental stability of that at-home parent is the greatest predictor to the success of the military family during deployment. And we know that during this time frame, our military families, and especially our military children, need the most support. Military families are at an increased risk of divorce. I think the OEF, OIF, we have seen the highest rate of divorce in the history of the military. So adding deployments and temporary duties to that mix can complicate things and accelerate the demise of an already troubled marriage. We also know that children experience somatic issues. They may report to the school nurse or to an urgent care provider with vague symptoms such as stomach aches or headaches. During the last phase of the deployment cycle is the reunification phase, and that can last up to a year, depending on the family. When that parent comes home, there could be apprehension, excitement, anticipation, but it also requires an emotional readjustment. You have a parent coming back into the family unit wanting to take back their role. So there can be a period of adjustment for that family. We also know, once again, this is a high risk for abuse. They're learning, and these children are often learning how to deal with the new normal, especially if that parent has an invisible or visible wound of war. A little bit of TLC goes a long way. So really encouraging these children to talk to an adult that they can trust. You want to focus on maintaining normal routines in their life. It's making sure that they attend school regularly, that they have a stable home environment. And you also want to know who your resources are in regards to counseling, whether it's with a psychologist, psychiatrist, or a school counselor. And it's critical that our military spouses on the home front have support, especially mental health support, to get them through this deployment cycle. Next slide. So why is this important? So this becomes significant in the clinical setting because approximately 75% of active duty military children and 100% of Reserve, National Guard, and the children of veterans are being seen in the civilian setting by providers who may be unaware of the military connection. Over half of providers, about 56% of providers outside of military treatment facilities, do not ask families about their military status or if they have a connection to the military. And most military families will not self-identify as spouses or children of service members, but there may be clues. On the active duty side, providers may be aware of military status based on the use of TRICARE insurance. For the Reserve, National Guard, or veteran child, there may be no distinction between them or any other patient in your clinic or your office. Continuity of care also becomes an issue as military families move frequently. So knowledge of military status is critically important in order to address issues quickly and provide resources and referrals. Knowing where the military family is in the deployment or relocation, by relocation I mean moving between duty stations, is important to providers, so providers can be proactive in establishing continuity of care. We also must ensure that civilian providers are equipped with the knowledge and education to provide culturally competent care to not only service members and veterans, but also their families to ensure that their healthcare needs are being identified and met. And like I said, there's a couple of studies out there that actually are showing that this is not happening. Siegel and Davis in 2013 found that pediatric providers feel ill-prepared to meet the physical, psychological, and behavioral needs of military-connected children. There was also a study in 2015 done by Fredericks and Nakasawa looking at knowledge and comfort level of caring for veterans in civilian clinical settings. And their data indicated an overall mild to moderate level of familiarity among clinical physicians in regards to veteran health issues. And their results did not reveal an overall high level of comfort with any of the issues included in the survey. And those issues were really looking at their physical and psychological health needs. And even though that study was based primarily on caring for veterans, it can easily translate to caring for the pediatric population as well. So next slide. So I was fortunate to have been selected to the inaugural cohort of American Academy of Nursing Jonas Policy Scholars and was the policy scholar for the Military and Veteran Health Expert Panel. They had already, by the time I joined the organization, they had developed their Have You Ever Served campaign. And when I met with my mentors to discuss my role with them over the next 2 years as a policy scholar, we discussed looking at the needs of military connected children and how to best support them, primarily because I am a pediatric nurse practitioner. So, having had that experience working with military kids, we wanted to see how we could translate what they had done with the veteran population into the pediatric population. And we knew that historically the needs of military connected children had gone unmet, and that at that time there were no existing guidelines or resources for pediatric primary care providers, including APRNs, to use to identify the unique physical, psychological, and behavioral needs of military children, or to screen for physical, psychological, and behavioral comorbidities secondary to parental military service. So hence the iServe2 campaign was developed with an aim to raise awareness to the unique health and educational needs of children whose parents serve in the military, both on active duty and in the Reserve and National Guard, and really to develop an evidence-based clinical guideline to serve as an aid for APRNs and other healthcare providers to identify military-connected children within civilian clinical practices. And we know that the use of clinical guidelines and pocket cards have been used successfully in clinical practice by healthcare providers to improve healthcare quality and are associated with improved outcomes. So basically, I modeled the iServe2 pocket card after the iServe2 initiative, really, like I said, looking to improve the health outcomes of military-connected kids. So when you look at the pocket card, it's a dual-sided pocket card. And on the front side, there really is that call to action, acknowledging the sacrifices military-connected children make in service in support of their parents' military service. Towards the bottom left of the pocket card is that prompt to the provider to ask their patients and the patient's parent, do you have a parent, sibling, or other military, or other family member who has served in the military? If the child answers no or the parent answers no, then you move on with your questions and exam. But if that patient or parent answers yes, really important to find out if that military member is active duty, if they're a reservist, National Guard, or if they're a veteran. Knowing what their status is can really guide you as to what needs that child might have. You also want to ask if your parent is ever deployed, because once again, this could clue you into certain comorbidities that child may have. And then you want to ask, where are you in the deployment cycle, and what is your time for relocation, so that you can provide the supports needed to help that child transition through the deployment or relocation cycle smoothly. At the top right, there's a basic overview of the deployment cycle. It really provides you with just basic information regarding risk assessment based on where that child is in the cycle. And then the bottom right-hand side provides several resources for providers, patients, and family members. There's several. I'll talk about some of these later on. Next slide. On the second side of the pocket card, we incorporated the iCare support strategy for military children. So the I stands for identify, really identifying who these military children are in your practice or community, identifying what risk factors or mitigating aspects those children might have, and if they have any patterns of coping. You also want to identify if the parent is active duty, reservist, or National Guard, so that you can gauge what services and referrals or resources might be available to that family. The C stands for correlate. So you really want to correlate what's going on with that military-connected child to what developmental stage that child is in. And you also want to make sure that you really address any concerns that the family or teacher has regarding that child. The A stands for ask. So you want to ask how that child is coping. You want to assess risks for physical, psychological, behavioral, social, and academic concerns. You want to conduct a vulnerability and safety assessment, because we do know that there are certain times that that child could be at higher risk. And you really want to be proactive versus reactive so that you can ensure a smooth transition through the deployment cycle and back into reintegration. The R stands for readying resources. Looking at who your partnerships are in your school system or in your community that you can help that family engage with. You want to keep a list of local and national resources for military families. And you really want to encourage these families to engage with those resources. And you want to start earlier than later. So you don't want to wait till that family is in the middle of a deployment to start engaging with these resources. You really want them to do that prior to the parent deploying. And then you also want to determine if that family has access to a military installation and what services they have available to them. And last, the E stands for encourage and educate. So you want to incorporate prevention strategies for that family. You really want to help build strong families and healthy problem solving within that family. And like I mentioned, early engagement with resources, and then help that family set expectations before, during, and after deployment. And then the right-hand side of the pocket card just gives you several examples of questions that the provider can ask to ascertain parts of the iCare support strategy. And then it talks about some resources that are potentially available. And then it also gives you a checklist for your vulnerability and risk assessments. Really asking that child, do you feel safe in your home? Asking the parent, do they have any concerns about their child? What does a typical day look like for you? How do you feel about your parent's job in the military? And how things have been going during the deployment or post-deployment. Next slide. So this slide is just a slide that provides you with some examples of resources available within the military as well as the civilian community at large to help support military-connected children and military families. As you can see, there's a whole host of organizations and groups on a military facility that you can encourage a military parent to engage with to support their military child. Also, religious organizations are another wonderful resource, everything from churches to youth groups to church mentors, some non-military groups and organizations. Most of the school districts across the country are getting on board and providing resources and education for military-connected kids. Scouting is a great opportunity for our military children. Different recreational, teams, team sports, clubs, volunteering is another way to, keep that child active and engaged. And then some other examples listed are pets, peers, sports, and friends. Next slide. So these are 4 specific resources that can be extremely helpful, not only for your military family, but also for providers to access. Military OneSource provides information and support to military families to overcome challenges associated with military life. They can provide everything from counseling, non-medical counseling for stress and anxiety. They provide financial counseling. They also have scholarships for spouses and children. They can help you with childcare options and support you and give you tips for moving and relocation. The Military Child Education Coalition really is focused on meeting the educational needs of the military-connected child to ensure inclusivity, quality educational opportunities, and really support that child during transitions, deployments, and family separations. The National Military Family Association really is an organization that works with the families and is the voice for military families to officials in the Department of Defense, Congress, and really help, they're the stakeholders when they're making key decisions to understanding issues facing military families. And Military Kids Connect is an online community for military children. The age range is about 6 to 17 years of age. It provides access to resources to support children who are dealing with psychological challenges of military life, and really helps that child prepare to face those challenges during deployments and relocations. Next slide. So the most important thing you can do for a military connected child in your practice is to be a patient advocate. Parental military service, regardless of when or where that veteran served, can have a profound impact, not only on the health of a veteran, but his or her family. So there are several things that you can do. First, you want to educate yourself on the unique health risks and healthcare issues of military-connected children within the pediatric population. The wars in Iraq and Afghanistan have been the longest protracted wars in U.S. history. And information is just now starting to get out there regarding the impact of war on family members. And we have a long way to go. Second, you want to ask the question, do you have a parent, sibling, or other family member who has served in the military? And once you ask that question, be sure to listen. You may be the first person this military parent or child has ever discussed this topic with. Be sure to incorporate the physical as well as the psychological and behavioral health concerns or issues into your physical or your history and physical exam. Using the iServe2 Pocket Card for healthcare providers caring for military-connected children will provide you with a template for addressing potential health risks, how to mitigate those risks through the iCare model, as well as provide resources in the communities to support military families. And be sure and document what that military child or parent tells you, because it might help them when they move to what information you put in that chart could potentially be helpful to that family as they move to a new duty location. Know who your referral agencies and options are in the communities. Schools are also a great source of information. And finally, support your military-connected children and families. Acknowledging them is really the first step, by providing them with your knowledge of the unique aspects of military life and a safe environment that is patient-focused, that allows them to discuss the impact of parental military service and that impact that might have, or the impact that may have had on their physical and psychological health, and providing with them with appropriate care referrals when needed is key to successful patient advocacy. Next slide. While we are just now beginning to see information surrounding military-connected children and their needs, there are many questions that still persist and need to be addressed. Everything from research to policy to practice. I think first we need to highlight the need for research funding for studies focusing on the impact of parental military service on military-connected children and the unique healthcare needs of military children. We also need an additional focus on the different experiences and exposures between the active duty military-connected children and reserve National Guard component children that needs to be included in that research, because we know that they have different issues and lived experiences. And we also need continued research on mitigating the impact of military life on the service member and the at-home parent. Next slide. I want to acknowledge my colleagues on this project, Dr. Wilmoth, Dr. Patrician, and Dr. Dumas, who are my mentors with the American Academy of Nursing, and Heather Johnson and Catherine Lang, who were colleagues of mine at Uniformed Services University, and then as well as some organizations that helped make this pocket card development possible. The Jonas Philanthropies, the American Academy of Nursing, and the Biden Foundation. Next slide. So before I move into questions, since Veterans Day is just around the corner, I want to thank all the veterans in the audience for their service, and thank you for taking time to be part of this webinar.
Thank you so much, Dr. Rossiter. That information was very helpful. We really appreciate all of the resources that you shared and all of the points that you brought up about servicing and the things to consider when working with a military-connected child or military-connected family. We do have a few questions. Okay. And one of the main questions that came up, and these actually maybe two questions you may want to answer, is in response, in your discussion about the responses to the military questions, meaning the questions you should ask or the clues to find out if a child is military connected, or where they are in the status of deployment or pre-deployment. Are those responses kept or retained in an electronic health record? And then also, if by chance it's a family that's moving around, is there a system, or how do you track the health record? If there is someone, where they may have seen someone else in another state and now you're seeing them for the first time.
So if it's an active duty child and they're being seen by a military healthcare provider on a military base, all that stuff should be tracked in their military health record. If they're civilian, unless that individual facility has some type of identifier, there is no national identifier for veterans on active duty or military families. So I do not believe that there would be any way to track them unless, like I said, a specific facility. I do know a handful of facilities actually have created their own identifier, but there is not, to my knowledge, a national identifier. And that is not only for children, but also active duty service members.
Okay, so basically you're pretty much relying on whatever information may be shared from the child or from the family, from the parents, in regards to whatever they've experienced in their history. Would you say that's right?
Yes.
Okay. And then also, I know you mentioned there are quite a few things that may come up in regards to risks. And you mentioned in one of the slides, like abuse and neglect, substance use, suicide. And I understand these things may occur for children in military connected families, but then also they may be in children, you know, who are not or non-military connected families as well. So would you have any guidance or recommendations on specifically how to address these issues, or things to identify specifically that may be different in handling them with a military connected child versus a non-military connected child?
So we know that these are, you know, these kind of instances can occur in both civilian children as well as military connected children. Some of the research that's coming out is showing that, especially in regards to suicide, that military connected children are at a higher risk of suicide versus their non-military counterparts or peers. Really just addressing, you know, having open and honest conversations with your military families. I think, first of all, even just identifying, knowing who they are. As I mentioned earlier, oftentimes these kids come into your clinic and nobody asks, nobody knows. So you don't even know if there is a risk for abuse or neglect. So once again, asking the question, knowing who these kids are, knowing where they are in the deployment cycle or the relocation cycle can really give you cues as to what resources or help that family may need. And the majority of them may not need anything. They may transition through these processes easily and without any issue, but you just want to make sure that you ask so you don't miss, you know, a child, or that child slips through the cracks.
Okay, thank you. And then in regards to the questions with the pocket card, I think that's a great resource. All of those questions seem really helpful. And one of our participants asked, would you recommend that you ask those questions from the pocket card each time or at every visit for the child?
I think you can use them, you know, I think you can use them as you deem needed. So, you know, for me personally, I usually ask all my kids, you know, do you have a parent serving? And then based on what's going on with that child or what they are coming in for, you know, we'll touch on some of them. Sometimes we touch on all of them. It just really kind of depends on what's going on with that child at the time. I think, like I said, just asking the question will kind of give you some ideas of where you may need to focus your questions. You may or may not utilize them all. I think, you know, touching base, you know, at a well child visit every year is a great opportunity to go through the majority of the pocket card. And then with your acute care visits, I think just looking at what's going on with that child and kind of focusing on that and where you might need to ask questions.
Okay, that sounds good. And then also in regards to obtaining them, I saw you listed some information on the pocket cards. So on the slide where you had it, so would that be a good resource in terms of how to obtain them if a civilian healthcare provider may have wanted to obtain them, or anyone wanted to obtain the pocket cards?
So the pocket card, it's available. You know, I'm happy to provide it to anybody. I know, you know, we're working with some school districts across the country to get it out into the schools. It's been published, it's copyrighted, it's been published, so it is out there. And like I said, I'm happy to provide the pocket card to anybody who would like a copy of it.
Great, thank you so much. And then also, I think this might be our last question. In regards to having these discussions, what would you recommend if, you know, your healthcare provider, you're asking these questions, but it seems like you may not be getting the information that you need, or, you know, maybe the family or someone's not comfortable discussing their military connection or what's happening. How would you recommend handling those situations?
Once again, I think it depends on the relationship you have with that family or that child. I think it's no different than any other patient that you'd work with, and when you're having either a difficult conversation or a conversation that your patient may not feel comfortable with. I think if you appear to be caring and you're engaged with that patient, I think oftentimes your families will talk to you. There's always referrals. So even if they will not discuss it with you and you have a concern, or you feel that there's something more that needs to be taken care of or discussed, go through your referral sources and refer that family member.
Okay, thank you so much. And I know you've also listed several resources in your presentation as well. So this information, this presentation webinar will be made available on our media library. So again, we thank everyone who joined us today, and you can feel free to visit our media library if you'd like to view it again at some point. Again, Dr. Rossiter, we thank you so much for your participation and your presentation. And of course, it looks like someone is asking about networking. Are you available for questions? Can they reach out to you after the presentation?
Yes, they can. Feel free to reach out to me. I'm happy to, provide you with any information that I have.
Okay, great. Thank you so much.
Thank you so much for the opportunity to present. I appreciate it.
Sure, it's always a pleasure working with you. And again, thank you to everyone who joined us, and we hope you have a great day. Thank you.
Thank you. Have a nice weekend.
You too. Bye-bye.
Bye-bye.